Are you curious about Gestalt language processing? You are not alone. Join me, Corinne Smoose, and speech therapy PD for our podcast, The Gestalt Get Together. Our episodes try to balance the enthusiasm and excitement about GLP and its associated intervention ideas, as well as a healthy dose of skepticism about how to understand and integrate this paradigm shift into your career and the field at large. We hope that you can get together with us to learn more about Gestalts.
Welcome to Brainstorms, Functional Neuro Rehab for SLPs, presented by SpeechTherapyPD.com. This podcast is designed for the adult medical speech-language pathologist. Most of our audience members work in settings such as acute care hospitals, private practice, outpatient hospital clinics, and inpatient rehabilitation hospitals. Each episode has an accompanying audio course on SpeechTherapyPD.com and is available for 0.1 ASHA CEUs. The content of this course is based on the research and experience of the presenters. The listener is responsible for researching to determine if the information and skills taught are appropriate for their clients, students, or patients. SpeechTherapyPD.com does not necessarily endorse, recommend, or favor the information shared, nor any of the claims, opinions, statements, offers, or services made by the presenter. Hello and welcome, everyone. My name is Renee Garrett, and I'm your SpeechTherapyPD.com podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for 0.1 ASHA CEUs. Here are the financial and non-financial disclosures. Courtney Welch is an employee of the Concussion Legacy Foundation, and she has no relevant non-financial disclosures. My financial disclosure is that as the host of this podcast and other webinars on SpeechTherapyPD.com, I do receive financial reimbursement. I'm also a paid employee of a private consulting firm in the Commonwealth of Virginia, as well as an adjunct faculty instructor for both James Madison University and Old Dominion University. My non-financial disclosure is that I'm the secretary for the Communication Disorders Foundation of Virginia. Now, without further ado, we welcome our guest, Courtney Welch, MS, ATC, who joined the Concussion Legacy Foundation in April 2023 as a patient services coordinator. Courtney previously worked in both the collegiate and clinical settings as a certified athletic trainer. Her understanding of concussions, sports, and healthcare fuels her commitment to supporting individuals through CLF's helpline and continuing education initiatives. Courtney graduated from Piedmont College with a bachelor's degree in athletic training and went on to further her education at Troy University, where she received a master's degree in kinesiology with a concentration in exercise science. Throughout her academic career, she developed an interest in the complexity of concussions and focused much of her research on learning more about them. Driven by her innate desire to help others, Courtney chose to pursue a career as an athletic trainer, where she's had the privilege of guiding countless athletes through the concussion recovery process. Having personally experienced the impact of concussions during her own athletic endeavors, she empathizes deeply with those facing similar challenges. Through her work, Courtney strives to make a meaningful difference in the lives of individuals affected by concussions, embodying her unwavering passion for compassionate care and support. Welcome, Courtney. So nice to see you again.
Thank you so much for having me.
Of course. So talk to me a little bit about your experience with athletics and kind of how that led you into this field.
Absolutely. So my background is in athletic training, and that came from years of playing sports growing up, primarily soccer. So I played from maybe 9 or 10 years old all the way up through high school, and ultimately decided not to play in college to focus on school, but also had several injuries that prevented, my ability to continue going. And thankfully, I never had very significant concussions while playing sports. I did have several concussions that were more mild that did require short times off from games and practices. But thankfully, I was lucky in that regard, but had many orthopedic injuries during my athletic career that made continuing sports very difficult. So loving sports and kind of being involved in it my entire life, I wanted to find somewhere that, made a lot of sense to combine staying involved in sports and athletics, but always loving medicine and healthcare and, helping people kind of, how do you combine that? So I did find athletic training, which I went to undergrad for, became a certified athletic trainer, and really enjoyed the combination that provided. But while I was in school, I learned a lot more about concussions that even I had no idea anything about, even though I played sports my entire life. I'd never heard of half of the things. I didn't realize how severe they could be, what symptoms, could happen and long-term effects. It was, really eye-opening just to learn how complex these injuries were, which really stimulated my interest. So I did focus my undergrad and my graduate research on learning more about concussions and specifically the mental health impacts that those can have on patients afterwards. So just really, loving that and being interested in it. And I did, work at Troy University as an athletic trainer and walked with many athletes. I had a soccer player who had 15 concussions.
Wow.
And ultimately had to retire. We had a football player who had some really significant long-term symptoms that he was facing. And, just seeing different people, different backgrounds, different medical histories, and how their recoveries varied so differently really just kind of furthered my interest in that. So I was very thankful when I found Concussion Legacy Foundation and learned more about what they're doing to, not only, prevent some of these long-term issues that athletes are facing, but trying to make sports safer so that we can, continue to play the sports that everyone loves, but in a way that is safer for everyone, without these long-term issues. So very excited to be a part of the foundation and working and, talking with people affected by concussions directly, every day and trying to help them navigate this process.
Well, and I think what a lot of people don't realize is just how prevalent concussions really are, and especially in that age group that you mentioned, that the teen athlete, the collegiate athlete, and even into the 20s, and for professional athletes who are basically most of their careers are done by the time they're in their 30s. I watch a lot of sports, and my husband is a huge Premier League soccer fan, and so go Arsenal. So my shameless plug in there because we're number one right now. But yeah, it's interesting because you listen to the commentators speaking about these athletes and how much, you think about the time investment and everything that they put into it, and they make them sound as if they're in their 70s or 80s when they're, 28 years old, and they're like, oh, well, they should probably retire because they're not as spry as they used to be. But a lot of that relates back, like you mentioned, to orthopedic injuries, but then also concussion history is a big part of this. And so let's kind of dive into some definitions and talk about PCS. So for those that are listening, post-concussion syndrome, and what that is and what that looks like for, especially for our collegiate athletes, but also just thinking about our geriatric patients who are at higher risk for falls, who can also have this same kind of syndrome happen to them.
Absolutely. Yeah. So, concussion is caused by a blow or a jolt to the head or to the body that causes the brain to move back and forth. And when someone gets a concussion, like you mentioned, whether that be from a fall or from an impact in sports or, any number of car accidents, there's many different ways those can occur. Those symptoms are typically presenting very close to injury, if not immediately within the first few days, and gradually improve over time. So an average concussion, you're going to see improvements day by day, maybe by 2 weeks or so, most symptoms are resolved. What we see with post-concussion syndrome, as we also call persistent post-concussion symptoms, is that those same concussion symptoms are lingering, they're ongoing, and a doctor's typically going to diagnose this after a month or two of the injury, and they're continuing to deal with these symptoms that are just persisting. They're not improving or not improving as quickly as everyone would hope. And that, can be a big challenge. And that's where, typically therapies and, more intervention is started to get those symptoms resolved. But unfortunately, it's fairly common. Research is showing like 10 to 30% of people who do have a concussion have these persistent symptoms. And obviously that varies with different demographics and medical histories as well. But, it's a big, a lot more common than I think a lot of people realize to have these persistent symptoms.
So let's talk a little bit about the symptoms, because when I've presented on this before, sometimes people are kind of astounded when I talk about this, and, they tend to have a lot more questions at this point because, we think of concussion as being something really mild. It's, actually classified as MTBI or mild TBI by a lot of providers. But anytime you gave the perfect definition, your brain is sitting there suspended in this jelly-like substance. So anytime it's smacking back and forth and hitting bones and things that are, the old law of motion, things that are in motion stay in motion. So when you stop, it stays in motion. So some of the symptoms that I know people sort of associate with concussions are maybe nausea, maybe headache. I know when I was a kid and I was an athlete too, and we had friends that had concussions, and the doctor would say, don't let them fall asleep. And everybody would always be sleepy and want to go to bed. And so I think those are sort of those classic symptoms that people equate to MTBI or a mild concussion. And I don't really like using mild concussion. I just know that is the terminology that's out there, because anytime your brain is hurt or bruised or injured, it's not mild. That's a big deal. And we'll kind of talk about that a little bit. But talk about a little bit about those symptoms that we see besides just headache and just besides the nausea or maybe some fatigue.
Absolutely. And I think one thing to consider with this as well is, a concussion, can be as simple. And again, I agree with mild is always a nervous word to throw out there, but you can have a concussion and have one symptom, and you can have a concussion and have a whole boatload of symptoms. So, that makes it difficult for providers, especially to kind of, and patients to navigate. But yeah, like you mentioned, headache is obviously a huge one. Nausea. We hear a lot of, eye sensitivity. So lights can be very bothersome, noises as well. So again, you're thinking about the old way of thinking things of, go sit in a dark room, but don't fall asleep, because these, any sounds, lights, those can be very triggering to someone who's just had a concussion. There's physical symptoms, there's, dizziness and loss of balance that can also occur as well. And memory issues, cognitive issues, not being able to recall, amnesia. Are you, do you know where you're at or what day it is, what time it is, what you were doing before the injury? And so there are definitely lots of symptoms, and we kind of break them up into those physical symptoms that we mentioned, the headaches, the dizziness, the nausea. And then there's the cognitive symptoms, the memory, the focus, difficulties that can happen. But we also see sleep is a huge factor in not being able to go to sleep or stay asleep or wanting to sleep significantly more than usual. And maybe the most surprising to a lot of people is the mental health symptoms are very common after a concussion, and anxiety, depression, those can really, without any history of mental health struggles before, those can kind of appear in the recovery period. And that can be very confusing. But again, like you mentioned, if you think about, we're talking about our brain here, if our brain is being injured, it's, physically injured, there's chemical changes happening and, all kinds of things that, really affect, how a person can cope and deal with different emotions, and very common to see mental health symptoms after a concussion.
Yeah, and that brings up a really great point because I had a patient, it's been about a year ago now, and she had a car accident. She was actually T-boned. And it was kind of an interesting story because she had gone to Florida to help take care of her mom, who had been, I think her mom had surgery, and she was going to rehab. She was older, and she went down to take care of her mom and got T-boned in the vehicle. And the doctor said she had NTBI, is what they put in the medical record, and a mild concussion, because that's always what I tend to see. But this lady actually lost consciousness at the scene and was airlifted to the trauma hospital. So that was definitely not an MTBI or a mild concussion. And she really had all of the symptoms you described of PCS, but no one had talked to her about it. And so she was very upset and even emotionally labile, like crying a lot and having these feelings of guilt where she felt like she had to explain to people why she couldn't do the things that she was doing prior to, because she'd been cleared medically, even though she was having balance issues. She definitely had fatigue. She definitely had the hyperacusis and the photophobia, so that sensitivity to sound and light. She really was almost like a case study for PCS and what that looks like, because she literally had components of everything. Executive function stuff, like she would try to drive because they cleared her to drive and she'd get lost going to the grocery store. And so we saw a lot of that with our military patients who had been in blast injuries that, again, were classified as, we just had a concussion, just sit out for 10 days and you'll be fine. And so I think that's sort of where my interest became a little bit more piqued, because I was already working in the TBI world. And this was, like 15 years ago. And so when PCS started becoming more researched and more prevalent in the literature, I'll say became very interested in it when I was working on getting my certified brain injury specialty. But then I started looking at also with CTE, because that, again, has been something that's more publicized, more researched, and we're finally starting to see those correlations between having these multiple concussions and then how CTE is actually preventable. And I don't want to steal all of your thunder and give it all away. So let's talk a little bit about what CTE is, and then we can kind of move into the differences between the two.
Yeah, absolutely. You hit the nail on the head. CTE is different from concussions and PCS in the sense that it is a degenerative brain disease. So it is completely preventable, but it is caused by repetitive head impacts. So you mentioned military, which is a fabulous example, the blast exposures of just the, repetitive blast after blast that cause this damage that sometimes will be diagnosed as a concussion, if it's significant enough to cause symptoms. But a lot of times we see that these are caused by non-concussive impacts as well. These, just repetitive hits. I mean, you think, linemen, football players, each and every time you go into a tackle, you're getting an impact, right? And these kind of accumulate and can cause some pretty significant long-term issues. So, it's not diagnosed during life currently. The only way to diagnose CTE, which is chronic traumatic encephalopathy, I don't know if we mentioned that, but is post-mortem. So a brain autopsy to take a look and see if that damage has occurred. But, like you mentioned, a lot of research is being done and we're making a lot of headway and hopefully being able to diagnose this during life soon. And with that then comes treatments and, the gates kind of open. But right now, it's really symptoms and ruling out other issues and other conditions that may be at play. But we see it most commonly, with patients who've had hundreds or thousands of these repetitive head impacts over many years and then progress. These symptoms typically are presenting many years after an injury. So different to a concussion or, post-concussion symptoms where these may be within days or weeks. We're thinking years later, now you're having memory issues and cognitive issues that are coming up, mental health issues that seem, even more confusing because you haven't had a recent injury. What's causing this? And so it's it's very complex, but very significant, and hoping that more and more research is, going to be done for us to really understand it better. But yeah, very, very interesting to learn more and more about it.
Well, one thing that I think is kind of interesting to note, and that I've talked about in one of my talks I did before, was that this actually research really started in the 1920s, when they were looking at boxers who had these group of symptoms that were different. And you mentioned the mental health component, and part of that was behavioral changes like being aggressive, or even in some cases being verbally or physically abusive. And those were people that had not done that before, had not had those types of behaviors before. And so the CTE research to me is so interesting because it gets down into like tau level proteins in the brain and all this other kind of stuff that is very technical. And so if you're someone who is listening and you're interested in that, definitely look at Concussion Legacy's webpage, because they have some really great research article links. And then they're also doing some really great research that, if you, and I'm probably pre-mentioning this because we're probably going to mention it again, but if you have a patient or you have someone that you maybe have in your care, like a family member or child or something like that, teen athlete, that you may be able to have them enrolled in a study, or at least look at the studies and see if there's a fit for your loved one. So what's something you would say a lot of people maybe don't know about concussions and PCS? I think we've talked about symptoms, and we've talked about the fact that it's really not mild. And that may be a good place to maybe delve a little bit into the mental health components, because you kind of touched on that a little bit. But if there's something else you feel like we haven't maybe mentioned that you wanted to mention.
Yeah, absolutely. I think there's, definitely several things that, like we've mentioned, the brain is complex, which makes the whole process confusing. One thing that, I work on our CLF helpline, which is where patients and caregivers reach out to CLF for resources, for provider recommendations and peer support and educational resources. And something we get a lot is this question of, not knowing, is it PCS or is it CTE? And it's very confusing, especially in this younger population, because their symptoms are very similar. We touched on the symptoms of concussions and PCS, and those cognitive, issues that you can have right after an injury. You can have those later down the road with suspected CTE, mental health, impulsivity. Again, those can happen in both situations. And so, again, we get that question a lot of, not knowing the difference in it. And I think the biggest thing to know is that, post-concussion symptoms, again, generally happen right after the injury, and they do get better. So with treatments, you're going to see progressive, improvements that may not be as fast as anyone wants. It may be weeks, months, or years, but you're going to, typically see most, if not all, of those symptoms resolve. Whereas with CTE or suspected CTE, those are going to be progressive. You're going to continue to have worsening of those symptoms. And they, again, typically present much later. Like you mentioned, the mild traumatic brain injuries, I think it's important for anyone listening, whether it's someone that you're working with, or if it's someone that you know personally, to know that, that's a medical diagnosis for medical reasons, but mild by no means, indicate that the symptoms or the injury is mild. You can have very significant symptoms with a concussion. And I think, realizing that and kind of giving that extra level of, care and understanding to anyone that you're working with, that, this is a significant impact on people's lives. It can really affect school and work and personal relationships. And again, the mental health aspects that we talked about. I think a lot of those are obviously the chemical changes and the, biological things that are happening. But also so much of it, I think, is, people don't understand. They're not understanding what you're going through. It's can be hard to even put that into words, what you're going through and what your symptoms are like and how that's affecting you. And I think that having that lack of understanding can really cause those mental health impacts, and significantly in the younger population, the pediatric population. I think research is showing like almost 50% of pediatric patients who have a concussion have these mental health symptoms. And you think of these younger populations, and again, it's confusing and it's hard to even put, normal day life in words sometimes, but add a brain injury on top of that, and it can make it very, very difficult to process what's going on, why these symptoms are happening, and very hard for other people to then understand, what they're going through.
Well, and I think one thing too is that a lot of people have told me, a lot of my patients have told me that the symptoms vary greatly throughout the day and from day to day. And so there were times when this one particular lady I mentioned earlier, she would say things like, well, I thought I was getting better and then I had a really bad day. Or I had 2 really good days and then the whole rest of the week was terrible. And so we would kind of try to piece out what that looked like for her, because she was having trouble sleeping. Some days she could fall asleep with no problem, and other times she could not, or she could go to sleep and not be able to stay asleep. So she would say, I've slept for an hour or two and I woke up and I couldn't go back to sleep. And then I got scared. And then she has this like whole full blown anxiety panic thing going on. And now she's in that cycle again. And so again, like you mentioned, if you think about that as a teenager or preteen, even early 20s, where your brain is already not fully formed and your frontal lobe isn't, doing what it does when you're 35, and you've compounded it with this injury that's caused all these other physiological changes inside your brain, then yeah, you can see how that could be really scary. And like you mentioned, confusing for that age group in particular. Add in hormones, add in school, add in, the pressures of bullying and things like that. So it's this whole big whirlwind of things that I think people just don't think about. And there's a really good story on, it's more than one story. There's a little video on YouTube I've used before that talks about adolescents and their return to school and having to really have an advocate, not only within the school, but with their caregivers or parents or whoever their caregiver might be, because sometimes those protocols that are in place are not a one size fits all. And not every adolescent or even collegiate age athlete is going to be able to go back to school in those 10 days and perform at the same level. And then if you're returning to the playing field, there's the concern for second impact syndrome as well, which is, not something that we put kind of embedded in the conversation in this particular podcast. But I think that's another area that people need to definitely know more about, because that can be fatal. And that's really, again, there's a lot more to this than just this, oh, I had a little bump to my head. It's not that simple.
Absolutely. And I think you brought up a great point with the protocols that are in place. And I know we've mentioned several times, the research that's ongoing. And, despite these injuries being around for a very long time, we're still just learning more and more about them. And those protocols are constantly changing. So, the old way of thinking of things is you get a concussion and you go sit in a dark room and you don't talk to anyone and you don't have any stimulation and you sit there until all of your symptoms are miraculously better. And then you just jump back into life. And someone without a concussion sitting in a dark room for many days on end, I don't think that's healthy for anybody. But, more and more we've, finally learned about this, and protocols have, changed even very recently to really wanting to integrate people back into activities and back into socialization very quickly because of how significant these mental health symptoms are. So, like you mentioned, advocates at school, there's going to have to be modifications that's made to allow, people to get back. But, I had a recent conversation of just the difference in return to learn versus return to school. And sometimes returning to school is very helpful, and just having that outlet, that socialization, that slight integration back into normalcy, although you may not be ready to take tests or quizzes or, things like that. And so, again, I think the more we learn about all of this, the better these protocols are. But we are, we're making improvements and changing these protocols to say, give your brain some rest. Like you mentioned, second impact syndrome, get out of sports, get out of things where you're going to risk getting hurt again, but don't completely isolate yourself into where you're sitting alone. You're facing these confusing symptoms and struggles by yourself. Have a support group, have people there who are caring for you and checking in with you. And that's really important after a concussion, especially. But when those concussion symptoms don't go away and you're still facing it, having that support in place to continue that support, continue those modifications as needed throughout your recovery.
Are you taking advantage of our new amazing feature? The Certificate Tracker. The free CE Tracker allows you to keep track of all of your CEUs, whether they are earned with us at speechtherapypd.com or through another provider. Simply upload your certificate to your registered account and you're all set. So come join the fastest growing CE provider, speechtherapypd.com.
Yeah, this was a male patient, and he got in a car accident. And the story was that he was actually at a stoplight, and he was rear-ended at a high impact, and he was unconscious at the scene as well. And the initial response was the first responders thought that he was high or, drunk or whatever, because it was later in the evening, but he was actually someone who works a shift where he came home later at night. And that assumption was made, and they actually gave him Narcan to revive him. And so he had a lot of concerns and questions because of the long lasting symptoms, because he did have PCS, about if that had any impact. And I was like, I really can't speak to that because I just don't know the answer. But he was also very independent, has a fiance, but he was, independently working, independently owned a home. His children were older. He had grandchildren that, would come spend the weekend with him and stuff like that. So it was very impactful for his life, because he would say there was some kind of simple things, or things that we think are simple, like he was the one who cooked meals. And so he would cook something and leave the stove on and not realize it. Or he left the water on. And it was interesting to me because there was a lot of correlation between what he was describing and my mother-in-law, who had Alzheimer's, even though he didn't have that. But there was things that were atypical, things that he was doing he had never done before, that reminded me of the things that she did, which is how we knew she was sick. But it was just interesting because, I said to him, maybe you need a checklist, like a safety checklist of, especially in the kitchen where things can, be dangerous if you leave something on and maybe leave the house, you could start a fire and all that kind of stuff. So we kind of ran through that. But he did call it the protocol, which is why I bring this up, because it was something we could easily customize for him based on what he was experiencing. And so I kind of got him to be the owner of the data at home. How many times did you forget to turn the stove off and then go back and realize? But he was very hesitant to use visual supports. And so I think, when we're thinking about obstacles for people in treatment, he felt like that. He called it the crutch. It's a crutch. I don't need a crutch. I need to get through this. I need to do better. I need to remember on my own. And I'm like, yeah, but you're retraining your brain to do something it knows how to do. You just have to access it and get that routine back. And it took a couple of sessions for him to kind of be on board. But I gave him the ownership of what things do you want to see come of this? Because people who listen know I talk a lot about shared decision making, because if people don't have buy-in, they're not going to do it. And so I think it's similar to this, in that if people, no matter the age, across the lifespan, if they're having these obstacles and challenges and no one is listening, then they don't feel seen, they don't feel heard. They're not going to continue to share, and they do start to kind of suffer in isolation. And so then having someone come in and try to do treatment, it makes that more of a challenge for everyone, because they're like, okay, well, if I don't say anything, then they won't know. And that does lead into that whole mental health cycle. And, again, you're not necessarily processing the information the way that it's designed to be processed, or the way that you processed it prior to the injury. And so I think for me, that's probably one of the bigger obstacles that I've seen across the lifespan with patients, is just that not wanting to be reliant on something that seems so simple, until someone points out that we all use our calendars and our phones. We all set timers. We all put, reminders on the refrigerator, or write a note to yourself, or make a list before you go to the store. Because what you're doing is setting yourself up for success, that you're going to be able to engage that motor learning of writing that list. So now you might remember. Whereas, like for me, if I go to the store, and even when I was in my 20s, I would know I needed 4 things. And I'd get to the store and I'm like, okay, I need 4 things. And I'd get 3. And that 4th one would be the mystery. And I'd buy some other crap I didn't need. And then when do I remember what I needed, that 4th thing? When I pulled in the driveway. It's the same sort of principle. And those are the obstacles just in the treatment room that I've seen. But what are some of the obstacles you would say people have that you have encountered kind of more in the athletic realm, or even in the concussion legacy on the helpline?
Absolutely. I think one of the most consistent things that we hear is the fact of just that concussions, post-concussion symptoms, even suspected CTE, any of these brain injuries or brain diseases are invisible injuries. So you run into these issues where people, whether it's friends and family, whether it's coworkers or people at school or even doctors, don't believe you or don't understand what's going on. If you thinking from an orthopedic standpoint, if you come in with a brace and crutches, no one's questioning why you're not running, right? It's visible. You can clearly see why this person isn't able to do X, Y, or Z. When it's an injury to the brain, you just can't. And so it's, again, the brain is having a hard time processing anyway. The patient may be having a hard time vocalizing the symptoms or, some of the struggles that they're facing. But even more than that, even someone who's very clearly able to explain, my sleep is really disturbed and I'm, sleeping in 1 hour increments. And, whenever I can try and get a nap, I really need to. And then you have the people who were like, well, you had your concussion 6 months ago. You don't need to take a nap. It's these people who, it's not something you can see. It's not something, unless you've been through it, that you typically understand, because again, it's confusing. It doesn't make a lot of sense sometimes, but it's very, very difficult for patients to advocate for themselves when they have this invisible injury that people don't understand. So we really work on our helpline, especially, and trying to educate caregivers, who are helping these patients, and, trying to educate them on, what are, normal, outcomes. And not that any of it is ever normal, because everyone's different, right? But, what are ways you can support someone with a concussion or post-concussion symptoms and suspected CTE? How can you understand that what they're going through doesn't make sense to most people? You can't see it, but it's very real for them. So, we do offer peer support groups that are amazing. We have one-on-one peer support where, patients are able to connect directly with people who just get it, who've been there, who understand, and that can be so important. But even thinking of it from a provider standpoint, I think so many providers are undereducated on what concussions are, what is a persistent post-concussion symptom, what is suspected CTE? And you have these patients who they may not even know or understand that it's because of their previous brain trauma that they're having these symptoms. And if they do, they may vocalize it, but if a provider's not really educated on that, then you have someone really trying to go out their way to get the help that they need, and that help is not out there. We hear a lot about this lack of access to the proper treatments. With PCS, symptoms improve with the right treatments, but getting the right treatments from the right providers who know and understand, okay, you're having this dizziness and this nausea and these headaches, 2 years after your injury, here's X, Y, and Z, there's things we can do to help this. It's really difficult to find those providers and find that level of care to give them what they need. So we try and educate providers through our, continuing education programs on best practice guidelines of evaluation and management of these conditions. But I think, for any provider, it's not only being educated from a, science and research standpoint, but just having that level of understanding and care when you're dealing with your patients who, may or may not be able to fully vocalize what's going on, just taking what they're saying at their word and giving them that level of understanding of, whether or not you fully understand it or not, I'm going to listen to you and we're going to get through this together. And, that's huge for these people who are going through these chronic conditions.
Yeah, no, I agree. Because a lot of times with this group of patients that I had, because I had 2 or 3 at the same time over this past year, one of the things they would say was, well, I don't feel like we really got anything done as far as tasks go today, because all I did was tell you how I'm feeling. And I'm like, well, sometimes that's very therapeutic, and that's exactly what you need. And so, for me, as a speech language pathologist, our treatment model is set up differently so that we have more of a space that's considered more of a safe space, and it's a little bit more private than being in the gym with 25 other people. And so a lot of times that's what happens is people come in and they're very cathartic, and they're like, this is what happened today, and this is what happened over the weekend, and why can't I do this? And I cried because I saw, my grandson kick his first soccer ball, or whatever it is. And they'll tell very intimate details of their life, and then kind of also feel guilty afterwards and think that they've taken up time for something that could have been a task practice or a task learning experience. But that camaraderie and that education piece is so, so important. And I tell my students that too, because sometimes it may not look like you're doing what we're taught in school, but sometimes that's exactly what your patient needs, is for you to be an active listener and a sounding board, and to let them know that what they're experiencing isn't crazy. Because that's the one thing that the lady and the other gentleman would always come in, am I going crazy? I'm getting crazy, right? And I'm like, no, you're not. You've had this thing happen to you that you didn't ask for, and no one's explained it very well. In some cases, people are seen literally in the emergency room one time and told to go home, rest, and follow up with their PCP in 2 weeks. Well, there's a lot of people who are and I'm not knocking PCPs. I have a wonderful PCP, so I have nothing bad to say about my experience there. But again, that's not the specialty area that's designed to provide education and treatment. And so if they haven't had the appropriate education or sought that out, and let's be honest, in healthcare these days, the way that things are time driven and productivity driven, it makes it a challenge for people to go out and seek out additional education in a realm that maybe is not what they do from day to day. So there's a lot of, I think, obstacles on both sides that people need to be mindful of so that they can refer if needed. And that's another piece that I've encountered quite a bit, is finding the right provider. But if you're not someone who knows what that looks like or knows the right questions to ask, some of the things that you can ask. I mean, I think we're so lucky when we're looking at generations. Like my father-in-law's just turned 81. When he goes to the doctor, he does whatever they say. Change the medication. Okay. That's what we're doing. We're doing whatever they say. My generation, I'm a little bit, younger, obviously, than him. I question things. I'm looking for the provider but I'm also in the healthcare field. So I think there's still a lot of people that are in my age group who are not always going to question. They're going to do what they're told. And I think that sort of trickles down. And there's a lot of other factors like health literacy, social determinants of health, and all those kinds of things that provide this intersectionality between healthcare access, quality access, and then having this other thing that you're trying to navigate. And it can be extremely overwhelming, again, on both sides of the fence, whether you're the healthcare person. But, if you're the healthcare person, you have a responsibility to refer to someone else if you don't have the competency and the expertise in the area. I just think that's a really important thing to point out, because the other obstacles, we know that there's a suicide rate increase too in this population, particularly with CTE or suspected CTE. And so I think that's another good point to bring up, because if you're not providing best practice and these patients are already experiencing mental health issues and then they feel more isolated, it just becomes this whole big circle, right? And so what would you say about that? What kind of research have you seen come out that talks a little bit about those mental health issues and how they can kind of be exacerbated by those factors?
Yeah, absolutely. Definitely incredibly, a major factor with the suspected CTE population, because there's these lack of diagnosis. There's this lack of, firm research or firm evidence on, what can we do about X, Y, and Z. But I think it's really important for any providers to ask the right questions and just, have this base level of knowledge about it, at minimum to know, to even think about asking about brain injuries. Someone may come to you for something that seems very different, and it may be related to brain trauma. But again, it's just kind of tying those loops together that can be difficult. And, the more we're able to educate providers, the better those outcomes are. But I think with mental health, especially, it's, the awareness of the fact that, these mental health issues are prominent in this population. If you think about the populations affected, military especially, that's even a higher level of, risk or concern because of, what they may have experienced in getting their brain trauma. And so I think it's, awareness of that at a base level. And like you mentioned, referrals, the earlier and sooner we can identify that this is a factor and asking the right questions, because patients are not always forthcoming in the struggles that they're facing, and referring them to the proper, mental health providers to do those evaluations and to get them the treatment that they need to prevent, that the risk of suicide and, further mental health struggles. So, I think it's this level of understanding that it really starts with, right, of just understanding, realizing, asking the right questions, and having the level of knowledge and acceptance of, I may not know the right things to do, but I can get you to the right places, and giving those referrals and those recommendations to help, prevent these catastrophic issues.
Yeah, and you mentioned kind of early on the return to learning versus return to school. And I think we see the same thing with returning to work. And so, a lot of times what happens is, again, people follow this model and they don't do this individualized care, which is really, again, something that I'm a huge proponent for. But looking at, can you modify the workday? The lady in particular had a pretty high impact job as far as her cognitive load. She did have to travel for work. She was under a lot of stress for the responsibilities of what the job entailed to begin with. And so what the doctor suggested was for her to go back half day, 5 days a week. And I laugh now because that just seems to me like I wanted to call him and say, what if this was your wife? Would you have told her she's telling you she's experiencing all these symptoms and she's crying in your office and you're telling her, oh, well, just go half days, 5 days a week, because that's so much better to work, 20, 25 hours half day than work your usual 40, 50 hours. And so I think, again, looking at those obstacles and barriers, because she was vocal about her symptoms. She was vocal about the difficulty she had with the emotional lability and being able to control that, particularly when she got fatigued, even frustration from her husband. And she'd been married for, over 30 years. And she was very frustrated with him because he didn't understand what she was going through. And so, again, these obstacles tend to layer themselves upon layer, especially when you feel like you aren't being listened to. It's just crazy to think that, if you mentioned kind of another example too of like if she went in and she had a broken leg, or say she'd had, a compound fracture and had to have hardware put in her leg and was non-weight bearing and not able to be mobile, no one's going to look at her and go, oh yeah, you should totally drive. You should totally go back to work and have to walk 300 feet and climb 6 steps to get into your building or to your home or whatever it is. Yeah, you're fine. Until people really get that and stop thinking about this as oh, we can't see it, so it doesn't exist. I don't know how to educate providers more other than, being vocal about it, almost to the point where I felt like I was being annoying sometimes, but sometimes that's how you have to be to get the message out.
Absolutely. Yeah. Broken records are sometimes the best thing we can do, right? Is just the more we can get that information into people's hands and, force it into understanding, is sometimes all we can do. Like you mentioned earlier with the patients, you can't make someone get help, right? You can't make someone seek out the correct treatments. They're going to, people have to do that for themselves. Same with providers. You can't make them change their ways of practice and change their philosophies on return to work and return to play and all of this. And so, again, I think having the knowledge as a patient, as the person doing that, just trying to be as educated as you can on what's going on and trying to advocate for yourself and having people try and advocate for you as well. But yeah, I mean, we see all the time where, legal avenues have to be addressed and disability has to be brought into consideration, especially, when you think of suspected CTE, there's, it can get to the point where the decisions that they're making are not the decisions they would have made 5-10 years ago, and they may not even realize that. So, having that support system who can identify, even like you mentioned, primary care doctors who may not be the most knowledgeable on neurology or brain trauma. They typically, know you pretty well, especially if you're older and going frequently for any other conditions. But, having people who are identifying, hey, have you considered, this and navigating people in the right direction? Because, again, it's how can we expect providers to know the best thing to do when patients don't know the best things to do? And, again, it's like you mentioned, it's the circle and it's never one thing. It's never just the inability to go to work. It's also, the inability to pay your bills on time and remember that, to pick your daughter up for school. And, there's always a multi-factor portion to any injury, but we just understand that more when it's something that you can physically see. And when it's not, that's where it gets very difficult for people to navigate. And, I think, again, it's just education and advocacy and, just beat it into their brain until they, understand it and accept it. But it's, it is the biggest struggle we face is just the lack of education, the lack of knowledge of how this works, how brain injuries work, how the brain is recovering after a concussion, how with suspected CTE, it's progressive, it does continue to worsen, and what are safeguards you can put in place? What are those checklists that you can have with a patient or with, a spouse? And once you realize that these checklists aren't working anymore, what's the next step? And just trying to, be prepared for what that journey looks like. And that's where we at CLF really try and come alongside patients and caregivers and tell people we're here for the journey. This is not a one-stop shop. It's not something that's, you get off the phone call with me and everything's magically fixed, as much as I sure would love that. I don't have my magic wand working yet, but I can support you. I can be a listening ear that can listen and can hear what struggles are you facing, what resources are out there, and let me do the research. Let me try and hunt down ways that we can help. And at the same time, I'm taking all that information that I'm hearing from patients and caregivers, and then I'm talking with our team, and I'm like, this is a huge gap. We don't have access to these resources. We don't have providers who understand, this situation or these symptoms. And then we try and, fill the gap with the education and the advocacy and, get that information across into other professions.
Yeah, and we didn't even really touch on the impact of trauma and how that plays too, because that's another area where when you're dealing with someone who's had multiple concussions or, the other impacts that different types of trauma can have, it does change those physiological components in your brain. So take the concussions away. Say this is someone who had trauma from something else, and then you combine that now with this, that changes things as well. And that would be we could probably do a whole nother hour just on that. But trauma-informed care is another thing that I talk a lot about because it does, in the population that I've tended to serve throughout my career with TBIs or PCS, it has been a very impactful component for their recovery, particularly when they were first diagnosed, because they have all this other stuff that they were already dealing with trauma. And so that's another piece where I think, having something like a helpline is really, really important, because it's important for people to know that they're not alone. Bottom line.
Yeah. And I think it's so easy to think about concussions and post-concussion symptoms and even CTE. It's in the news in sports, right? We hear about it with football or rugby, and military starts to creep in sometimes. Sometimes we hear about it there, but even that's newer. But, I think there's so many areas where, just thinking about trauma alone, law enforcement and first responders, a huge area of clients who are, struggling with histories of brain trauma and histories of trauma in general from other factors. We think about domestic violence patients and victims of domestic violence, and, they have so much going on that the brain injury is sometimes the last thing that providers are thinking about, or again, it's not always discussed. It's not always talked about, but there's so many other, demographics of people that this affects that have these additional layers of trauma to it that, like you mentioned, just really further complicates the care.
Yeah. Well, I think this was great. And I thank you so much, Courtney, for spending your time with us and providing us with more information and education. And what I'll do is just ask for resources so that we can put them in the show notes so that our listeners can access, the website and anything that you feel like is relevant that will be helpful and supportive. So again, I thank you so much for joining us and for being so forthcoming with the information you shared today.
Absolutely. Thank you so much for having me again. I've appreciated the invite and love speaking with you, and we'll be eager to, help anyone that we can through CLF. We'll get some resources over to you.
Thank you.
Thank you so much.
If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete address in your account profile prior to the course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to be reflected on your ASHA transcript. Each episode comes with an accompanying audio course on speechtherapypd.com, available for a 0.1 ASHA CEU. And just for our listeners, get $20 off any subscription with promo code BRAINSTORMS20. SpeechTherapyPD.com is run by SLPs for SLPs. We've got the largest library of ASHA CEU eligible courses out there, adding fresh content every week. Remember, use BRAINSTORMS20 to get $20 off access to over 1,000 courses for an entire year. Head over to SpeechTherapyPD.com for more information and start earning CEs today. Thanks for tuning in to Brainstorms, Functional Neuro Rehab for SLPs. And don't forget, SpeechTherapyPD.com is your go-to for all things ASHA CEUs. Your positive reviews and support mean the world to us. We'd love for you to drop us a quick review and hit that follow button.